Three, two, one. Good evening, our dear friends and viewers from all over the world. This is Thursday Clinical and Guidelines at CEC Cardiology Education Channel. Tonight is a very spectacular, extraordinary, super ordinary night because we have one of the most famous cardiologists in Egypt, our dear professor, Dr. Suleiman Gharib, professor of cardiology at Cairo University and former vice
Thank you.
president of Cairo University as well. He's one of the most eminent figures in the field of preventive cardiology, hypertension, and dyslipidemia in our country and in the whole region. Professor Suleiman offered us generously his time and his contribution tonight, so we are greatly honored to have him with us. We will have an introductory, very interesting lecture about low high density lipoprotein, low HDL, as a specific and maybe less well established risk factor for coronary artery disease. This will be presented by Professor Haitham Suleiman, lecturer of cardiology at Fayoum University. And then we will have a discussion with Professor Suleiman Gharib regarding this particular issue and regarding other factors also incorporated in the non-routine lipid profile that should be also well known, like lipoprotein little a, apolipoprotein, and so on. And then this will be followed by a case-based discussion with Professor Hatem Sukari, Professor of Cardiology at Tampa University. Professor Hatem will discuss with us the diabetes and dyslipidemia in the form of a clinical case-based discussion with different scenarios regarding this particular situation and its effect on the lipid profile and the risk for every particular diabetic patient. So after this short introduction, I will pass the mic to my dear friend, Professor Haitham Suleiman, to start sharing his slides about the interesting topic about HDL when it is low and how this affects the cardiovascular risk of our patients. So Professor Haitham, you have the mic now.
Thank you, dear Zahran. Um, I will try to simplify my topic as much as I can. The problem with HDL that because it's not considered as a target for treatment, we forget sometimes about the HDL. We slip it into our minds when seeing a lipid profile, and we do not have entirely um, the configuration, what's the role or function of the HDL. So in this very small video, we see the APO A1 rich particle, which is the immature LDL, HDL, collecting cholesterol from foam cells in the atherosclerotic vessels from the SRB1 receptors, and then delivering this cholesterol into the liver at SRB1 receptor, thus doing what's called by the reverse control transport, cholesterol transport, and decreasing the cholesterol burden inside the blood vessels and decreasing the magnitude of atherosclerosis into these vessels. Again, the HDL molecule, which is consisting mainly by an ApoA1 lipoprotein, go and collect the cholesterol from the foam cells, then deliver it into the liver, thus decreasing the cholesterol burden into the blood vessels. So HDL has another indirect pathway into eliminating cholesterol and HDL by exchanging this cholesterol with triglyceride from the lipid or the cholesterol-rich other molecules like VLDL and LDL, and then deliver it again to the liver. So the cholesterol is transported via the HDL by two mechanisms: by the direct mechanism collecting the cholesterol from the formed cells, and by indirect mechanism by exchanging this cholesterol in return to triglycerides from the VLDL and LDL and transporting them back to the liver. Of course, the other direct method is the LDL receptor engulfing the LDL-rich cholesterol into the liver. So these are the two mechanisms by which the body can eliminate or cholesterol from the blood and manufacture the important lipoproteins with these cholesterol, either by recepting the LDL or via the HDL transport, either direct transport or indirect transport. This created another concept, switching it from calculating the HDL and the LDL into calculating the HDL and non-HDL molecules, because all the non-HDL molecules are competing against the HDL into acquiring the cholesterol. So this concept and this function of the HDL creating the new measures called the non-HDL cholesterol, either than giving attention into the HDL numbers and the LDL numbers alone. So what causes HDL to be low? Either it's a familial or primary causes or secondary causes. The familial or primary causes are the most important because they are less known and they do contribute into coronary artery disease in an earlier stage of life. We have a familial ApoA1 deficiency, a familial LCAT, which is the lecithin cholesterol acetyltransferase deficiency, and the Tanger's disease. Secondary causes are extremely common, including all the metabolic syndrome components: obesity, type 2 diabetes and pre-diabetics, cigarette smoking, physical inactivity, end-stage renal disease, high triglycerides, high dose of thiazide diuretics and beta blockers, very low-fat diet, severe liver disease, malabsorption, malnutrition, and severe inflammatory diseases. These are too common and they are repeated in our patients thoroughly, rendering the LDL low. So primary causes are mainly genetic defects in the ApoA lipoprotein synthesis. There is low HDL and sometimes low LDL. Strange enough, most of them are not accompanied by coronary artery disease because of the low LDL accompanying the low HDL. HDL function and not only its count or its level is altered, meaning that we can find a normal HDL level, but with advanced atherosclerosis, because the function of the HDL in the collection of cholesterol is also altered. And usually they have a corneal opacities in young ages. Another primary cause, which is the most dangerous, is the Tanger's disease, which is a mutation in ATP cassette transport 1. It has low HDL up to 5 milligram per deciliter and low LDL. The ApoA1 levels are
كنت بس
low.
بقى الصبح ولا هي انا هحصلهم حالا دلوقتي.
Cholesterol ester
Hello?
deposition in reticuloendothelial cells is present. This accelerates the HDL catabolism. These patients have orange tonsils and peripheral neuropathy. And these patients, the most important thing that matters, have premature coronary artery disease. So Tanger's disease is one of the HDL defects that's accompanied with premature coronary artery disease despite the low LDL levels, which is very important. If a primary cause is suspected, we should evaluate the HDL and its component, meaning that we should estimate the levels of ApoA1, ApoA2, and other HDL subfractions, and we must measure the LCAT enzymatic activity as well, because this can be the only clue to prove that we have a genetic defect or primary cause of low HDL. Secondary causes are very well known to all of us: metabolic syndrome, smoking, low-fat diet, high triglycerides, and drugs like high beta blocker or high thiazide diuretic doses. And this should be taken into consideration when treating a patient with coronary artery disease, because we do give these patients beta blockers, and sometimes we reach a high doses of beta blockers. So it must be taken into consideration the level of HDL and whether this level is decreased or not, despite the treatment with statins. The clinical presentation is like any presentation of dyslipidemia, tendon densitomas, cutaneous densitomas, ischemic coronary heart disease, signs of congestive heart failure, arrhythmia, and corneal opacifications. This will give us another clue that HDL is not well known and its function is not well understood till now, because there is entity of patients called the A1 melano patients, or ApoA1 melano group of humans that have remarked low HDL level and remarked low incidence of atherosclerosis. This means that it's not the quantity that matters regarding the HDL, but also the quality or the function. These entity of patients or entity of humans have a very hyperactive HDL that have a lower levels, but hyperfunction that decrease or regress the plaques into the atherosclerotic patients. So what's the significance of low HDL? Low HDL is considered as a risk factor for coronary artery disease. And low HDL tends to have high non-HDL or LDL levels. So low HDL is considered a risk factor, despite it's not a target for treatment. And levels below 40 milligram per deciliter in men and 50 milligram per deciliter in women is an independent marker of atherosclerotic disease. Studies have tried to link between the HDL and triglycerides, HDL, low HDL, and high LDL, and others have tried to link the ApoA1 levels with low HDL as a direct cause of this risk, or these levels of low HDL. So all these trials are trying to have a connection between the ratio of triglyceride HDL, the ratio between the HDL and LDL, and the presence of decreased ApoA1 either count or function, to emphasize the role of HDL in protecting patients from the coronary artery disease. So do the reverse counts, do high HDL levels have a significance? HDL levels higher than 60 milligram per deciliter is an independent negative risk factor in both sexes. So high HDL is considered as a protective factor from coronary artery disease or atherosclerotic disease. At 60 milligram per deciliter, one risk factor can be subtracted from the individual's overall risk profile. And every 1 milligram per deciliter increase in HDL is associated with a decrease in cardiovascular risk by 2% in men and 3% in women when treating a patient with atherosclerotic heart disease. So let's rise the HDL. The first drug that targeted the levels of HDL and increased HDL was the niacin. And it increases remarkably the HDL levels of these patients. The aim high, in the aim high trial, the addition of niacin to statin therapy did not provide any clear benefit to patients with cardiovascular disease and low HDL levels. And in a larger study, which is the HPS2 Thrive study, confirmed the findings that increasing HDL alone was not protective for the patient. So the patients are into continuum. It's not only rising the HDL that counts, but addressing every aspect of atherosclerosis of these patients is the countable. Despite high HDL or rising the HDL decreases the risk, but it do not decreases the overall risk of these patients. It decreases one entity of risk, um, which is not efficient enough to protect these patients. So, still in the guidelines, statins and fibrate raise the HDL with similar magnitude, and thus drugs may be considered, but still in the guidelines, these are not target to treatment. So let's try not to degrade the HDL from its components in order to increase the HDL level by the CTAP inhibitors. Most of the randomized trial tried to increase the levels of HDL by the CTAP inhibitors, but none of them proven efficient in decreasing the mortality significantly of the patients. And that's why till now, the patients, the HDL is not the target for treatment. And what about HDL, high HDL in CKD patients? The protective effect of HDL is altered in patients with atherosclerosis and chronic kidney disease. Alteration of the protein cargo and small molecules such as symmetric dimethyl arginine is the cause of the loss of HDL of its protective function. In this patient, increased HDL cholesterol is associated with adverse cardiovascular outcome. So, high HDL and very high HDL and very low HDL have the same outcome. They do tend to increase the risk of the patients. And why is that? Because the function of the HDL with an abnormal high concentration, the HDL loses its function. So we are not happy to have an abnormal HDL of 19 milligram per deciliter, because this reflects a risk factor for coronary artery disease, as we have an HDL of 20 or 30 milligram per deciliter. So what's the benefit of HDL value after all these discussions? The benefit is to refine the risk of the patient. After calculating the conventional score of this lipidemic patient, it is refined by the HDL level, which can switch a patient from an intermediate risk category to a higher risk category if he has a lower levels of HDL. So till now, the levels of HDL or the role of HDL is in the estimation of risk more than the protection from atherosclerosis. And that's why in the guidelines, it's class 1 indication to calculate the HDL once to refine the risk estimation using the online score system, and to calculate the non-HDL cholesterol and to analyze the ApoB fraction of the LDL as well. It's also recommended to measure the lipoprotein little a once at the adult life to identify those with very high inherited lipoprotein little a levels, which is another component of atherosclerosis, and to refine the risk of acute cardiovascular events and the familial hypercholesterolemia. Again, till now, the HDL is not recommended as a target for treatment. So in conclusion, low HDL has many primary and secondary causes. It's an important marker for increased cardiovascular risk. HDL function is more important than its level. Aims to increase HDL failed to be of benefit. Till present time, HDL levels may reflect positive or negative risk factor, but it's not a target for treatment. And thank you so much.
شكرا يا هيثم. الو
أي فندم أنا مع حضرتك.
دكتور هيثم شكرا على البرزنتيشن. الو
أي بي أنا مع
سامعني
حضرتك.
يا هيثم؟
أنا سامع حضرتك.
Thank you very much for your presentation. You tried to make the problem as easy as possible, but I would like to highlight some point. In our research in 1992 for hypertension incidence in Egyptian, we found that the majority of the Egyptian has a low HDL, less than 35. And this make them susceptible for coronary heart disease, as you said in your talk. But the problem for HDL is a number. HDL is not one type. HDL is the 3 types. If we look to the reverse cholesterol transport mechanism, after you apolipoprotein A goes to the macrophage and take the cholesterol, the ABC, which is ATP binding cassette protein, change the cholesterol to nascent HDL. This is the first type of HDL. Then the LCAT, hello? Hello? Then the LCAT changed this nascent HDL to the mature HDL3. Then the LCAT another time, make the LDH3 HDL2. Then it goes to the scavenger cells to the liver to be changed to bile acid and excreted in the bowel 30%. Therefore, we have at least three forms of HDL. But there is something amazing here. If the HDL is protective for the coronary artery disease, how can we ignore its effect in the management of coronary artery disease? How to the guidelines ignore the effect of HDL? Do you know? If the HDL if the HDL is less than 45, 70% of the people got coronary artery disease. And if it's lower than 35 milligram per deciliter, the effect in the blood vessel is great. Okay, Haitham, I would like to answer.
I think this is caused by the several trials trying to increase the HDL as a target for treatment, starting from the Illuminati to the Reveal trials, with a failure to increase a benefit in decreasing the cardiovascular effect.
Increase HDL without decrease the LDL? It should be combined.
Yes, but in the Reveal trial, which was the only trial that shows little benefit, they increased the HDL by 104% and decreasing the LDL by 17%, which is not sufficient for the LDL. So I think these trials had a severe defect in its design because all the evidence now is with the decreasing of LDL to more than 50%. So I think if there is a design in a trial to increase the HDL to 100% and decreasing the LDL more than 50%, which is the recommended now, I
This
think
is
we
very
will
good.
have an added benefit, because
Yes.
all other trials did not decrease the LDL sufficiently.
Yeah, you are right completely. You are right completely. We have two weapons. We have to decrease the LDL up to or down to 70 or 50% from the original, or increase the HDL to 60 or above 60. Okay, thank you very much, Dr. Haitham.
Thank
Will
you,
be
sir.
the next speaker.
Do you have any questions from?
Can I add a comment, Haitham, please?
Please do.
There is a problem with the cholesterol ester transferase protein inhibitors, which is aldosterone-like effect and causing hypertension. And the earlier trials of CETP inhibitor showed increased in the mortality actually. This was not evident in the latest trial. However, it's still there, and there is an increased incidence of hypertension and increased evidence of adverse effect with the using of these drugs. So this may be the cause of negative results in this trial, which
Or
is
withdrawal
no,
of the drug.
no, sir. With the drugs causes has aldosterone-like effect, so it causes increase in the hypertension, increasing in sodium load, and there was an increase in the adverse effect, especially in the Illuminati trial. So the component of the drug or the structure of the drug, maybe it's a cause of the negative results of these trials.
You're right, Karim, but in the latest trial, the reveal, the ensitropib did not have this deleterious effect on systolic blood pressure. As we see here, the increase was 0.5% in the systolic blood pressure, and despite that, the decrease in the incidence of coronary artery disease or atherosclerotic events was only 9% down. So even when they tried a CETP inhibitor that did not cause this marked increase in systolic blood pressure, they did not get any benefit, any significant benefit in decreasing the atherosclerotic burden of these patients.
Okay.
Okay.
Dr. Haitham, who is the next speaker?
Professor Dr. Hatem Sukkari.
السلام عليكم ورحمة الله
عليكم
وبركاته.
السلام بروفيسور دكتور حاتم.
دكتور سليمان، ازي حضرتك؟
ازيك حبيبي، اخبارك ايه؟
الحمد لله.
اهلا وسهلا بيك.
I'm so happy، يعني it's my honor.
I'd like to welcome
الانترنت كويس.
I would like to welcome you very. Who is?
I'd like to welcome Professor Dr. Hatem Sukkari. He is an eminent professor in Tanta University, and we are going to speak about a special scenario of this on dyslipidemia, which is dyslipidemia in diabetic patients. So, Professor Dr. Hatem, please share your screen.
Can we also welcome Professor Dr. Muhammad Suteha and Professor Dr. Magid Habib? They are joining us tonight. So
Hello.
welcome, dear professors.
الو
دكتور محمد.
الو، ازي حضرتك؟
ازيك يا فندم؟
دكتور اي سامعني؟
الو.
ايوه يا فندم، احنا
دكتور
سامعين
سليمان، ازي
حضرتك.
حضرتك دكتور سليمان؟
دكتور محمد،
كل سنه
حاولت
وحضرتك
اتصل
طيب.
بيك اقول لك مبروك.
ربنا يبارك
حاولت
فيك.
اتصل بيك اقول لك مبروك، بس تقريبا انت ما بتكلمش الناس اللي مش رؤساء اقسام دلوقتي.
لا يا بيه، يا بيه احنا تلامذة حضرتك يا دكتور سليمان.
ربنا يخليك يا حبيبي، الف
تلامذة
مبروك.
حضرتك ونشرفنا هذا يعني
الله
كل
يكرمك
مكان
يا
يعني.
حبيبي، الله يكرمك
والله
يا حبيبي.
وحضرتك
ألف مبروك.
استاذنا ومعلمنا كثيرا جدا يعني.
ألف مبروك. ألف
علما
مبروك.
وخلقا يعني. ربنا يخليك يا دكتور
ربنا
سليمان.
يخليك. اتفضل.
الله يبارك في حضرتك.
دكتور هيثم can you help me share my screen؟
تحياتي لدكتور هيثم على المحاضره الجميله اللي سمعتها بصراحه. يعني ربنا يكرمه ان شاء الله وينفعنا به ان شاء الله باذن الله تعالى. وبرحب بدكتور حاتم اخويا الصغير. ربنا يخليك يا هيثم. وبرحب بحاتم اخويا الصغير.
الله يبارك
وحاتم من الناس الامننت عندنا يا دكتور سليمان، واحنا محملين عليه جزء كبير جدا من المهمه بتاعتنا في القسم. والله الحمد لله يعني. ربنا يكرمه يا رب.
دكتور هيثم can you help
Hello.
me share my slides
Sure.
closed for me?
Flo, I stopped sharing my screen, so
I can. No, it still gives
بس
me
بس
able participation.
السكرين مش
Can you
مش
try?
واضح.
Can-
مش
Okay
ظاهر.
now. Okay.
okay.
بيعمل لودنج دلوقتي.
Go
اوكي.
ahead, Dr. Hatem. It's clear now.
Okay.
Okay, go ahead.
Okay. First of all, thanks to my professor, Dr. Sulaiman Gharib and Dr. Mohammed Stiha to give me this chance. It's my honor for Dr. Sulaiman to be my moderator and discussing with me. He is my previous supervisor in my master degree before, but maybe he don't remember. Thanks for CSE group about management of dyslipidemia in a special situation. Actually, we were planned to discuss dyslipidemia in diabetic and chronic kidney disease, then in patients with chronic liver disease, and then in case of rhabdomyocytes. But I think for time, I make it two parts. This part today for diabetic dyslipidemia and chronic kidney disease. Then we will discuss the others in another presentation. Bismillah ar-Rahman ar-Rahim. This is a case scenarios based on review of the guidelines of European Society of Cardiology and European Atherosclerosis Society in 2019 guidelines. As you know that atherosclerosis is the leading cause of cardiovascular morbidity and mortality worldwide and constitute 1/3 of all deaths worldwide, while this figure is more in Egypt. Dyslipidemia is the most prevalent, important, modifiable risk factor for atherosclerosis. In Europe, it's 4 deaths per year, and in Egypt, atherosclerotic cardiovascular events represent 38% of all deaths for sorrow. Our case today is a female patient, 42 years old, Egyptian, non-smoker, obese with body mass index 32 kilogram per square meter, with a 7-year history of hypertension, which is controlled, diabetic since only 9 years. She has negative family history of coronary artery disease or CVA. Asymptomatic, on medication candesartan 16 milligram plus hydrochlorothiazide 12.5 for hypertension, metformin 1000 milligram, sorry, it's 1000 BID, and glimepiride 3 milligram once daily. Her blood pressure range is 120/70 up to 130/80. However, her serum creat is 1.7 milligram per deciliter. Albumin creatinine ratio is 86 milligram. Hemoglobin A1C 11.2. She is not controlled. Total cholesterol 182 milligram. Total triglycerides 395. LDL only 71. HDL is 32 milligram. It is low, as mentioned by my colleague, Dr. Haytham before. So our first question to all my colleagues, audience, regarding atherosclerotic disease risk, can we judge this patient risk? Is it low risk, moderate risk, high risk, very high risk? Score of the European is more than 10. Can you vote, please? What's your opinion, my professor, Dr. Haytham, regarding this patient profile until they answer or help us to answer the risk of the patient for atherosclerotic disease. What do you see, sir?
So I think this patient, the presence of diabetes in this patient may render the score or calculating the score is not suitable or is not needed in this patient, because diabetes is an independent entity of risk of this patient, like the coronary artery disease or the atherosclerotic coronary artery disease and cerebral artery disease, and patient with very high LDL. This is the third entity, which is the diabetic patients. So diabetic patients are a special group of patients that are considered high risk for atherosclerosis, and we don't need actually to calculate their score. This is according to the European guidelines. We need to see if there is an additive risk for these patients to target the LDL of them.
Yeah, that's correct. We have a lot of issues to discuss in this case. Number one, she is female fertile at the age of 42. This is important. Number two, she is obese and hypertensive, which is risk factors. Number three, she is not long-standing diabetes, only 9 years. However, at the same time, she is enrolled with hemoglobin A1C 11. She is mixed dyslipidemia with triglycerides 395. And by the way, the issue is mainly for internist more than cardiologist. I just discussed it before maybe 1 week in the Egyptian Cardio Prevention Congress, that the most important for primary prevention is the education and of internist and GP more than the cardiologist, because usually you see this patient after she developed atherosclerotic cardiovascular disease, come to cardiologist, or atherosclerotic cerebral or peripheral, going to neurologist or vascular surgeon. And usually when she go to internist, if he is not or she is not well educated or pay attention to how to judge, how to calculate her risk or to consider a risk, she will look that she just uncontrolled diabetes and she has hypertriglyceridemia and start to give fibrate to elevate the HDL and to reduce the triglyceride, and serum creatinine 1.7 is not too much, and the patient is well controlled the blood pressure, and she will not pay attention to the role of a statin. This is my first message. What about the Dr. Haitham and Dr. Ahmed Saeed?
Yes.
Ah.
Go ahead, Dr. Haitham.
Choose A or B or C.
For me, this patient is considered as a high-risk patient. C.
I believe the presence of the chronic kidney disease and albuminuria define it as a target organ damage for diabetes mellitus, and it can be classified as a very high risk patient.
I agree with you. It is very high risk patient, especially this patient has diabetes since 9 years. Very high risk. Hello?
Yes.
So we have a problem with Dr.
Yeah. So let's discuss with Professor Dr. Suleiman the presence of risk enhancers or risk modifiers in diabetic patients. Like Dr. Hatem said, this patient.
I'm sorry. I get disconnected and I came back.
No problem. Can you share the slides again, please?
Okay. Now I will share. It's clear? Okay. Okay, Dr. Haitham, can I continue?
Yes, please.
Okay, so very high risk. So what is the point of view here? If we go for assessment of atherosclerotic cardiovascular disease, this is, yes, as we said, the score of cardiovascular risk chart for the high risk region in Europe and Middle East. And by the way, this is not for diabetic patient, as we said. Why? Because diabetic patient, chronic kidney disease patient, those above 75 years old, those with blood pressure more than 180, and those with cholesterol more than 300 or 8 millimole are out of this chart and considered high risk or very high risk, and we should deal with them aggressively. And by the way, the recommendation of the European Society of Cardiology for the high risk countries or what's called extreme risk with mortality rate more than 150 per 100,000, and Egypt, one of them, as 38% per death is due to atherosclerotic cardiovascular disease. So if it is high risk, we consider it very high risk. It is very high risk, we can consider it like extreme risk. We should pay attention for this. So any diabetic patient in Egypt, we look for as high risk or very high risk. This is one. And if we look for this trial, which is ProCam study in 1988 in 5,000 patients, dyslipidemia alone is more dangerous than diabetes alone by maybe 6 times. If we are combining the factors, diabetes, hypertension, and dyslipidemia, the risk of myocardial infarction is 114 in 1,000 patients. So this patient is diabetic, hypertensive, and also dyslipidemic. So it is at high risk or very high risk. How to judge? This is the very high risk patient. If we look here, we found either the patient to be documented atherosclerotic cardiovascular disease or to be diabetic patient with target organ damage or at least 3 major risk factors or onset more than 20 years, especially if type 1. This patient only 9 years and has only another 2 risk factors, which is obesity and hypertension, but it has target organ damage. And if we look here for the notice down, that we will find that target organ damage defined as microalbuminuria.
He has a problem.
Patient has microalbuminuria or chronic kidney disease with diabetes, which is diabetic nephropathy, it should be very high risk. Right. When to consider her high risk only? If she is without target organ damage and normal kidney function, but with duration of more than 10 years, here 9 years only, but or another additional risk factor, she has 2 risk factors. So if she is normal kidney function, we'll consider her high risk. The new category added by the European Society this last year is the moderate risk. First time to hear that the diabetic patient could be moderate risk. If it is type 1 diabetes less than 35 years old, type 2 diabetes less than 50 years, like our patient, but duration less than 10 years, like our patient, but without risk factors and without target organ damage, at that time we'll consider her moderate risk and we can give her moderate intensity statin only. Okay, go for the next question. What is the target LDL goal for this patient? 40 milligram, 55 milligram, 70 milligram, 100 milligram, 116 milligram. And by the way, the baseline is 71. Can we vote, please?
You consider this patient as very high risk.
Yes.
You consider this patient as very high risk.
Yes.
Therefore, the target of the LAD should be lower than 70. 55 is reasonable for me.
Sure, yes. So she is 55 milligram, sure. However, this patient LDL is 71. Here, this is intervention strategy that the very high risk patient consider the same as secondary prevention. We should go for lifestyle and consider drug therapy if more than 55 milligram. Okay. But in this case especially, shall we depend on LDL to be our goal target? If we review the lecture of my dear colleague, Dr. Haitham, we can answer. Is it yes, must, يعني which is guideline class 1, or should class 2A, or maybe class 2B, or no class 3?
I think we can give a couple of seconds for all our colleagues to
yes,
vote.
I think we should give them a chance to answer.
But I would like to highlight some point here.
Yes,
This
sir.
patient has a total triglycerides more than 300. And it may be the part of the problem, because the LDL is integral part of the equation. LDL equal to cholesterol minus triglycerides over 5 plus HDL. If we control to some extent the triglycerides, I think this patient may we can help this patient to decrease her LDL. We have to look to the triglycerides as a problem.
Yes, I need to raise this issue also, but I did not put it as a question. Shall we treat the patient first to control his diabetic state until he go for euglycemic state to be less than 7 or around 7% HbA1c, and then judge the lipid profile and decide? Or shall we start at case of hypertriglyceridemia and give mixed fibrate and statin? Or shall we treat with the statin only and control diabetes?
My humble opinion, Dr. Hatem, is to start at once the statin treatment using a high-intensity statin, regarding that this patient is a very high-risk patient, to decrease both LDL to 55 milligram per deciliter or less, and to help decreasing the triglycerides as per guidelines. The triglycerides is more than 150 in a very high-risk patient, so we should decrease the levels of triglycerides to less than 150 milligram. Using first high-intensity statin, then considering adding another drug to the statin treatment if we do not reach the goal for triglycerides, LDL, or both. So I think
I will say my opinion later.
Okay.
I think to add the
we have answers. Yes, sir.
Do we have answers from YouTube?
From the audience?
Is there any debate in the answer
from the audience?
I think we should move on.
Okay.
Dr. Hatem?
Dr. Sulaiman, you are about to say something?
Yes.
RB. So the answers is with class 2A. We should depend on
LDL.
LDL as our goal of targets. The answers from audience is
Okay.
I think for the sake of the increase markedly the triglycerides, we have to add fibrates from the start. This patient is diabetic, has LDL, whatever it may be the number, but it is a small particle LDL, which is highly atherogenic, and we have to control it. And in addition, we have to give a potent statin, like rosuvastatin.
Okay, let's to see in the future slides. If we go for this, for me, the answer is no. I will not depend on LDL, never. And why? Because how to calculate or how to check LDL in our lab. In our lab, LDL is calculated. It is not given directly. Maybe little lab, which is big lab, the machine extra millions to check LDL directly. However, LDL is calculated by total cholesterol minus triglyceride over 5 minus HDL. And they said, yeah, and if we go
plus HDL. Triglycerides over 5 plus HDL.
Plus HDL?
Yes, we
Seeking
combine.
we're seeking the LDL and not the total cholesterol. So I think it's minus the HDL.
Minus, sir. Minus. Let's to see. Okay. So LDL, this is a case from reality. Her total cholesterol 182. I review it with the lab. Her triglyceride was 395, and her HDL is 32. So LDL is 71. It looks nice. It looks nice. However, it is a deceiving figure, which is affected by triglyceride level. And by the way, if triglyceride is more than 400 in a patient, you should look for prevention of pancreatitis. Some said 500, but usually above 400, you should seek to reduce triglyceride by any way to avoid pancreatitis. In this case, I will not reduce it by adding of fibrate. I will reduce it by control of diabetes first. Once diabetes is controlled and HbA1c reduced from 11 down to 8 or 7, triglyceride will come down and there will be no need to add fibrate. And we can depend on statin only. So the old school in the management of diabetic dyslipidemia is to, in this case, is to give fibrate and statin. And as they give fibrate, they are afraid to give high dose statin or high intensity statin or high dose of high intensity statin. So they do what's called not actually the correct. They do it midway. So the risk of atherosclerotic cardiovascular disease will not come down and may even increase. So what to do? Diabetic dyslipidemia represent a cluster of lipid and lipoprotein abnormalities, including elevation of both fasting and postprandial triglyceride. And postprandial triglyceride has a direct relation to atherosclerosis. A small dense LDL could be LDL normal, could be low, but it's small, dense, and atherogenic and should be treated. Low HDL and low ApoBA1 level. Non-HDL and the apoprotein or apolipoprotein B are good marker of this patient for the remnants and the atherogenic part of cholesterol. And they are secondary object. If you have a good lab, in this case, that can give you apoprotein B, depend on it in management directly. If you don't have, go for non-HDL, which is better. Non-HDL has the same target of LDL plus 30 milligram. So if the target is 55, the target of non-HDL will be 85. If 70, it will be 100. 100, it will be 130. Apoprotein B is the same like LDL plus 10. So if the target is 55, it will be 65. If the target is 70, it will be 80. If the target is 100, it will be 110. And by the way, we use non-HDL and apoprotein B only in high risk and very high risk, not in moderate or low risk. This atherogenic dyslipidemia is one of the major risk factors for cardiovascular disease in type 2 diabetes, and especially with those with abdominal obesity and in patients with insulin resistance or impaired glucose tolerance. And as previously mentioned by Dr. Haytham, this is the non-HDL particles, very low density and and intermediate density and low density and small dense low density lipoprotein. And by the way, despite very low density, intermediate density are rich in triglyceride, in the patient of diabetic dyslipidemia, they are rich also more and more for cholesterol than non-diabetic. So I will depend on non-HDL for this patient to treat. And if we remember the patient, it's a figure, total cholesterol 182, and its HDL is 32. So its non-HDL is 150. What's our goal here for this patient? 70, 85, 100, or 130. I think it is easy to be answered. As before, we said we will add 30 to the 55, so it will be 85. Okay, so this is by the European 2019, that in this case, non-HDL 150, very high risk patient. So we will go for this figure, which is non-HDL 85, which is equal less than 2.2 millimole, the same like 55 milligram LDL. Okay. As we have here, diabetic patient with target organ damage. So, in patient with type 2 diabetes at very high risk, LDL reduction at least 50% from baseline plus goal less than 55 milligram. What it means, for example, if we consider this patient doesn't have mixed dyslipidemia and its LDL is 71, should I treat? Yes, I should make it down less than 55. But this is not enough. We should go also for 50% reduction. If we say 71 milligram, 50% reduction means less than 35 milligram. This is what it means by class 1A. Also, in patients with type 2 diabetes and high risk only, LDL reduction will be less than 70 and 50% reduction. So if this patient is high risk and diabetic and high risk only, and the LDL is 71, I will not say, okay, it is enough. No, I should go for 50% reduction also. Another point that statins are recommended at type 1 diabetes who are at high or very high risk. Type 1 diabetes or insulin-dependent diabetes that come in younger age is a special entity that we should treat if high risk or very high risk, not the same like those with type 2 diabetes. Intensification of statin therapy should be considered before the introduction of combination therapy. This is another point which is different from physician to physician. For example, as said by dear Professor Dr. Sulaiman, he said we can give fibrate with statin. For this case, I should not go for a very high dose to avoid complications. For example, some physician see it is better if I give rosuvastatin 10 milligram, I will go for 20. If not respond, I will go for combination or I will go for 40. If I give atorva, I will give 40 milligram. If not respond, they are either to give 80. Some say no, I will give 40 plus ezetimibe. However, it is class 2A. That means should, but you can, according to the patient status, see what to do for him if he found is high risk for complications to choose the lower dose. If goal is not reached with the statin, you can combine with ezetimibe, should be considered. However, statin therapy is not recommended for premenopausal patients with diabetes who are considering pregnancy or not using adequate contraception. This is very important in our patient. She is female, 42 years. That means she is still fertile. And we should ask her, are you planning for pregnancy, another pregnancy? If she said yes, we should not give statin therapy. And at the time, we will think about others like niacin. But if she said, no, I'm not planning and I'm using contraceptive method, and we are sure that she is not to get pregnant, mostly, we can at that time start our therapy. Another important point, which is class 2B, which may be given, is statin therapy should be considered in type 1 diabetes or type 2 diabetes less than 30 years old. Now we have a lot of patients, young, less than 30 years, about 20, 25, and we found that they are diabetic. In that age, who are young and usually not yet get target organ damage, and usually did not get hypertension, and usually maybe not smoker or obese, or have only one risk factor, can we consider it moderate? Shall we give a statin or not? At that time, if she has evidence of target organ damage, I should at that time put in mind to give statin therapy. Also, if LDL is more than 2.5 millimole.
Can I interrupt you if you please?
اتفضل يا فندم.
لو العيانة في الchild bearing period وهي في high risk, I have to prevent إن هي تبقى pregnant and I have to treat الأول atherosclerotic cause الموجود فيها، لأنها لو جت pregnancy هتدخل في complications، لكن مش الريفيرس. ايوه انا خايف ان التراتوجينيستي بتاعت الستاتينز وبتاعت الايفكت بتاعه، لكن كجنرال الزملاء اللي هم بيسمعوا I have to prevent pregnancy until I reaches a suitable level of LDL to avoid the current complications which can be run without any symptoms. Okay.
Yes, yes. For this patient, 42 years old, and she has chronic kidney disease and risky for complications, whatever to go through end-stage renal disease, to go through other complication of diabetes like retinopathy or neuropathy, to go through atherosclerotic cardiovascular disease. I should treat her first. I should control her first before thinking about pregnancy, and I should ask her to take contraceptive method. But if I found her by accidentally pregnant, I will stop.
No, you
to
have
clarify,
to stop.
I have to stop. For this patient less than 30 years and diabetic, I give him statin if there is target organ damage or LDL more than 100. Here, the only exception to change the target of LDL. More than 2.5 means about 100 milligram LDL. This is difference because you consider it moderate risk. The treatment goal for this patient, if she is smoking, to stop, healthy diet, lifestyle modification is very important, physical activity, body weight, control blood pressure, she's already controlled, and non-HDL or ApoB to be considered as secondary goal. Regarding the triglyceride, no goal, but they said in the guidelines, it should be less than 150, as it will be indicator for low risk. But if it is a higher level, it indicates need for look for other risk factors. And by the way, if you have a treatable cause for triglyceride, you should go for. If not, you will think about combination. And by the way, in this patient, we have hyperglycemia as a cause in diabetic patient, uncontrolled diabetes. If we controlled and found it still high, we should go. But if it is more than 500, for example, I think it is beyond the hyperglycemic cause and should be treated also immediately to avoid acute pancreatitis, which is a fatal condition, until the patient got controlled and then reassess. Lifestyle modification, including diet, exercise, management of obesity, smoking cessation, and alcohol. And regarding what medicine will choose for this patient, which medications we will prescribe for this patient to treat dyslipidemia. Atorvastatin 20 milligram, rosuvastatin 20 milligram, simvastatin 80 milligram, atorvastatin 20 milligram plus ezetimibe, rosuvastatin 10 milligram plus ezetimibe. Choose any answer or two answer or three answer as you like.
في هنا advantage بتاع الكومبينيشن ثيرابي الاتورفاستاتين بلس الازيتامايب decrease the side effect of the statin and improve the results because 30% of the collected cholesterol excreted in the stomach and the intestine then reabsorbed. Ezetimibe prevent this 30%. That is to say, I antagonize 70% from the total cholesterol in the body. Therefore, I favor combination therapy from the start, atorva or rosuvastatin with the ezetimibe.
Yes, I know even in our culture, in the Egyptians, we have a lot of diet bad habits and a need for cholesterol absorption inhibitor to be added. It will help a lot. I agree with you, sir. And however, if the patient give you history of that he did his best regarding the lifestyle, I think to go for maximum statin first, if you are not afraid of complications. We will discuss in another presentation the risk factors for complications that help the patient to go through side effects or complication. If not present, you can go for higher. But if you are afraid, you can go for lower. Dr. Haytham, any answer from the YouTube?
So, dear professors, before hearing from the YouTube, Professor Dr. Suleiman has given us his modification to the guidelines, or based on the vast experience that he has, that the Egyptian patient has a special situation in consuming a lot of fat. So the combination from the start is better for this special situation, from sticking to the what's said into the guidelines, to start first with the high intensity statin with the largest tolerable dose, which is here the rosuvastatin 20 milligram, and instead depends on a lower dose of a statin with ezetimibe, which will be more suitable for the Egyptian society. And this reflects what our professors and Professor Dr. Suleiman is always saying, that the guidelines are guide for treatment, but they should be tailored according to every special situation. So if we stick to the guidelines or the recommendation of the guidelines, we will start first with the rosuvastatin 20 milligram, which is B. But if we do a modification according to the patient diet history, we can go to the combination from the start. I think, am I clear, or I am right?
Yes, clear. Some professors also have another opinion, that to go for naive patient who did not receive before, to give high dose statin first until you go for 50% reduction. If you found that he reached to give 50% reduction in the first 1 or 2 months, give him a chance for another month. If not, you can add ezetimibe or to increase the dose. This is another story. However, if we go here for our case, we found both are correct. You can give Rosuva 20 milligram as a start. You can give Rosuva plus ezetimibe. Why I did not choose Atorva plus ezetimibe? Because Atorva 20 is considered moderate intensity, not high intensity. And this is one of our problem in Egypt. We don't have in the market as a commercial, Atorva 20 plus ezetimibe is not available too much. And also there is no Rosuva plus ezetimibe till now in the market. However, the best is either
No,
to
we
give
have
Atorva 40.
we have rosuvastatin and ezetimibe.
Most of it is 10 or 40. Less only is 20 is available.
10,
most of them
okay,
are 10
okay.
and
Okay.
40.
The bigger is better. The bigger is better in this case.
Yeah.
We have
so if Atorva 20 I will not choose, but Atorva 40 plus ezetimibe is available, which I will choose. But from these answers, I will not choose 20 because it is not the suitable dose. Either to start with 40 alone or to start with 40 plus ezetimibe.
You are right.
Here Atorva 20 is not enough. Semva 80 is high intensity, but the highest complication and disagree by the FDA in the last years. So we will never give 80 milligram. So the best answers are Rosuva 20 and Rosuva 10 plus ezetimibe, and then go up to Rosuva 20.
Can I interrupt?
Yes, sir.
Doubling the dose of simvastatin from 40 to 80 only give the chance of 60% of the improvement in the condition, 6% only, rule of 6. Therefore, the side effect of the Simva 80 is greater than its benefit.
Yes. So here, the recommendation, it is recommended that high intensity statin is prescribed up to the highest tolerated dose to reach the goal set for the specific level of risk. This is, I am also against in the European, because sometimes our patients, if not well educated, they lost their follow-up. And if you have a patient lost his follow-up with highest dose intensity, Rosuva 20 or 40 or Atorva 80, it will be a problem if you got complications. So I prefer to go for 10 milligram Rosuva, 40 milligram Atorva, and then combine and then go for highest. If goal is not reached with the maximum tolerated statin, combination with ezetimibe is recommended. And they said for primary prevention at very high risk, as the same of our patient, if the goal is not reached with statin maximum dose and or maximum tolerated dose and ezetimibe, or if the patient is intolerant to statin, at that time, combination with PCSK9 inhibitor is recommended. Usually, from my opinion, I restrict PCSK9 inhibitor for secondary prevention with multiple events, which is extreme risk, and those with familial hypercholesterolemia as is very high risk category, which is dangerous and come in young age. But you can, if the patient can, you can consider him if intolerant to statin and there is no available other substitution like bempedoic acid, which is available now in Europe and soon will be in Egypt. At that time, think about PCSK9 inhibitors. For very high risk patients, as we said, and intolerant, we can think about PCSK9. It is class 1A. Also, if the goal is not achieved, statin combination with bile acid sequestrant may be considered diabetic class 2B. As, for example, in this patient, low HDL, and you can give and something like that. So this is the algorithm that you assess the total cardiovascular risk and the baseline LDL or non-HDL. Then you will go for lifestyle for every patient, and then you will go for drug therapy for this case. We will go for high potency statin at highest tolerated dose. If not reached, you can add ezetimibe. If not reached, you can think about PCSK9 inhibitors. How to choose a statin? As we said, this is Atorva 40 and 80, and this is the Rezuva 10 to 20. You can see that the LDL reduction here is about 50%, and here is about 55%. And as my professor, Dr. Sulaiman, said, 80 milligram Simva reach up to 50 or 60, but however, it will go for complications. And Rezuva can be given up to 40 milligram. However, from my opinion, I will restrict it for patients in acute coronary syndrome in intensive care for the first month. And I think not all of us go for 40 milligram before giving combination. So the primary statin used for high intensity in this case will be Atorva 40 or 80 and Rezuva 20 or 40. That give you more than 50% reduction, which one of our target to go for than more than 50% reduction. What about, do you afraid from side effects? Yes, but I'm afraid more from drug interaction, especially for old age, not for this patient. Maybe she take only some anti-diabetic, some antihypertensive. If she has drug interaction or not, we can see. The atorvastatin is metabolized through cytochrome B3A4. That was previous state cytochrome B450, but rosuvastatin is away from this and metabolized through cytochrome B2C9. So it has the least drug interaction with any medications. So if you have a patient with a multi-medication, you can start by Rezuva, not Atorva. For example, this is the drugs that interact with statin, either and maybe lead to increased risk of myopathy or rhabdomyocytes. Maybe the most important of them for us is the calcium antagonist, which can many patients, depending on calcium antagonists in their antihypertensive, especially if combination with ARBs or ACE. So in that case, it is preferred to go for rosuvastatin. And here also, some drug interaction that need you to reduce the dose of Semva or Atorva. And if I will reduce the dose of atorvastatin less than 40 to be 20 or less, I think at that time, and don't exceed 20 milligram, at that time, I will not get the benefit. So if the patient is taking clarithromycin or itraconazole, I will not give atorvastatin. If the patient is taking immune suppressive drug, I will avoid atorvastatin. The only drug interaction known for rosuvastatin is colchicine. If the patient is on colchicine, he can get into myopathy or rhabdomyocytes. And if on antacids, take care that it will decrease its efficacy by 50%. So in case of Rezuva, we should avoid colchicine and antacids. This is nearly the last question. Let's to go out from diabetes and to say if our patient is not diabetic, what will be her risk category? Is the patient low risk, moderate risk, high risk, or very high risk? Let's to go back for her profile. She's female, 42, non-smoker, obese, hypertensive, negative family history, and on candesartan and hydrochlorothiazide, not diabetic, no anti-diabetic, blood pressure 120/70, and serum creatinine the same, albumin creatinine ratio the same, total cholesterol, triglyceride, HDL, and LDL are the same, and the HbA1c is 5.7. She is not diabetic. Shall we make her high risk, or very high risk, or moderate risk, or low risk? Can we vote? Dr. Haytham, regarding diabetes that we discussed, do you have any remarks or something that we did not speak about?
No,
summarize?
I think we've covered most of the issues with the diabetes. We need to know the patient's GFR. So is it normal or not? To decide the next question. But regarding the diabetes, we've covered almost all the aspects that we need to know about the diabetic patient and statin or dyslipidemia.
Yes. What's surprising in this patient is her GFR after calculation. You know, there is a difficult formula to calculate estimated GFR. But if there is easy application on the internet and mobile to judge the GFR, including that you speak about the age, the gender, the serum creatinine, okay, and the race, if she is black or others. And when
the weight also.
The weight, the race, the age, the gender, the weight, and the serum creatinine. And when I entered all this data, I got astonished because I found her GFR is only 38. I was thinking
there is something wrong.
Yeah, is it something wrong?
Yeah, because usually this patient, if the GFR is lower than 40, the creatinine, and this patient, to my experience or to my age and experience, the creatinine should be exceeds 2, not than 2.
Yeah,
I think
did you do
patient is small in build.
Did you do abdominal ultrasonography? Did you do an abdominal ultrasonography for the kidney? Show the echogenicity of the kidney?
Yeah, no, I don't have this. I refer her already for nephrologist if she is like that. And by the way, this patient, I refer her already for nephrologist. But when I speak about this, what they say, when you should transfer first serum creatinine, which is from 1.7 to be by micromole. So you will multiply by 88.4. It will be 150.28. This is one. Okay. Second, you will go for estimated GFR. So you will, if you put creatinine 150, female, I think there's something wrong. Yeah, it is coming. I think there is something wrong because my calculator did not give item for body weight. I think there's something wrong. Anyway, we will consider her GFR 38. Okay, I will consider it.
All the data make this patient is high risk.
So
all these data consider this patient as high risk. If we
Yes.
exclude diabetes.
If we exclude diabetes, it will be high risk. If we add diabetes, it will be very high risk.
Very high risk.
This is what I want to say. If you look for the patient and found his serum creatinine looks nice or looks just elevated 1.8, 1.8, 1.9, 1.7, even 2, you said no problem. It is mild renal impairment and no problem. Why to give? And I will give only treatment for triglyceride. LDL is nice. Total cholesterol 1.8 is nice. And I just will give fibrate to elevate the HDL and reduce the triglyceride. And she is controlled. Why to exhaust myself and to reduce her body weight. However, if we look thoroughly, we should first calculate the estimated GFR, and we will find that the patient is moderate chronic kidney disease stage 3. We have from stage 1, 2, 3, 4, 5. From stage 3, considered high risk, stage 4 considered very high risk, and stage 5 very high risk, which stage 5 means on hemodialysis, and in the stage renal disease if she is already on statin or has another risk factors to be considered very high risk. But if the patient came to you already in dialysis, another story. So our patient here is non-HDL is 150. She is also mixed dyslipidemia because LDL is low, triglyceride is high, but there is no diabetes as a correctable cause for hypertriglyceridemia. So I think here we should give her combination of fenofibrate plus rosuvastatin. And non-HDL here will be 100, and our target will be 70 as high risk. It is recommended for patients with chronic kidney disease initiated from stage 3 to 5, considered to be high risk or very high risk for atherosclerotic cardiovascular disease. And the use of statin or statin plus ezetimibe is recommended in non-dialysis dependent stage 3 to 5. In patients already on statin or ezetimibe or combination at the time of dialysis, he can continue his drugs. There is no problem. However, if the patient dialysis dependent who are free from atherosclerotic cardiovascular disease and the naive patient, not to commence statin therapy and to start statin therapy is not recommended. Also, another point, if the patient is old age, and more than 75 years old, who went to and diabetic or chronic kidney disease, who went to treatment of a statin recommended for all the people with atherosclerotic cardiovascular disease, whatever the age, the same as young. So if he is already secondary prevention, he will go for high intensity statin. But is recommended for primary prevention in less than 75 years old, the same like young. Above 75 years old and primary prevention, if he is high risk or very high risk. However, I should start statin at low dose, especially if there is significant renal impairment or potential for drug interaction, and then titrate up until LDL is controlled. What I mean, if patient 80 years old, for example, and he has renal impairment, I should go for low dose atorva or rosuva. Or if he has drug interaction due to age process and another comorbidities, I should take care about drug interaction. But if the patient looks healthy and looks what's called good, you can start at low dose and go up without afraid. Another point of view for this diabetic patient, shall we do glycated hemoglobin every now and then and blood glucose? Is it different? If the patient is pre-diabetic, metabolic syndrome, or non-diabetic, I should check regular hemoglobin A1C, especially those at high risk of developing diabetes who are taking high intensity statin. Up to 9% of cases on high intensity statin, and they are prone to be diabetic or pre-diabetic, can go through diabetes. And so which group I think about this, and I will go to do serial hemoglobin A1C every now and then, those old age, metabolic syndrome, obesity, and insulin resistance. Another fantastic issue that I found while I'm doing my search to do my presentation is a recent trial, meta-analysis done on 31,000 cases, and I think maybe it will have a role in the next guidelines, published in November 2019, that high-intensity statin are associated with increased incidence of hypoglycemia during hospitalization of individuals not critically ill. So if I have a diabetic patient admitted to hospital but not critically ill, they said take care about high intensity statin, that you should follow up serum hemoglobin A1C and serum random blood sugar. Why to do in which patient? They found that in patient with low serum albumin less than 3.5. Till now, I don't know why, but this I found it by chance. I go to the summary. If you have anything, dear Professor Dr. Sulaiman and dear Professor Dr. Haitham, if you have any recommendation before I'm closing my presentation, go ahead. I'm listening.
شكرا جدا للبرزنتيشن اللي هي كامله وكان فيري سمبل سمبليفايد وانت دايجست الماتيريال كويس قوي قوي. لكن هرجع تاني للايكويشن. انت كان عندك العيان بتاعك العيان 395 التراجليسرايدز.
تمام.
اوكي. لما نقسمها على 5 تطلع 79.
مظبوط.
والاتش دي ال 32.
تمام.
لما اجمع الاتش دي ال زائد التراجليسرايدز يطلعوا 111.
هو
لما اطرحهم من انا اقول لك لا اصل انت هي ماينس يطلع بلس. لما انا اطرح ال 182 111 يطلع لك 71 ال دي ال. تاني تراجليسرايدز 395 هقسمها على 5. هي الايكويشن بتاع ال دي ال بتساوي التوتال كوليسترول ماينس نفتح قوس التراجليسرايدز على 5 زائد الاتش دي ال. يعني الاول اجمع الاثنين دول واطرحهم من التوتال كوليسترول. يبقى المعادله بتاعتي التوتال التراجليسرايد 395 على 5 تطلع 79. لما اجمع معاهم الاتش دي ال 32 تطلع 111. في الحاله دي بقى لما اطرح ال 182 111 يطلع لي ال دي ال 71.
I think both equations, dear professor, are the same but are written differently. The equation of Dr. Hatem did not include the brackets, so
صح.
that's why they
هو عمل
subtract
بلس
minus and minus. If we included the brackets, it will be the fifth of triglycerides plus the HDL, and the sum of them is subtracted from the total cholesterol. So I think there are two different equations.
So Haitham, can I ask a question?
It will come يعني nearly the same message that LDL is not too much high, and if we depend on it, we will go for wrong decision.
Dr. Hatem,
Go ahead, Karim.
Can I ask a question regarding the hypertriglyceridemia in the diabetic patients? Of course, the treatment and the control of diabetic state is important for the correction of hypertriglyceridemia. However, it is recommended now to use a newer agent such as icosapent ethyl, which is a purified form of omega-3 fatty acid for treatment of hypertriglyceridemia. So, what do you think, Dr. Hatem, about the use of these drugs in these very high-risk diabetic patients?
I agree with you, dear Professor. I agree with you. However, my opinion is first to start by statin as per guidelines and control diabetes. If the diabetic patient is easy to be controlled, and then I will assess triglyceride. That's what I mean. If triglyceride at that time come down less than 150 or less than the target, less than 170, خلاص, okay, I will not give except statin. If it is more than 150, more than 200, I will think about icosapent ethyl to be added. Also, except if the patient is more than 400, I think at that time we should go directly, immediately from the start to add icosapent ethyl or to add fenofibrate. Number one, to reduce the risk of pancreatitis. Number two, to reduce the risk, especially for if the postprandial triglyceridemia is very high. You know, there is great difference between the guidelines regarding the triglyceride and to be mild and moderate and severe. For example, the Europeans say severe is 800. American Diabetic Association speak about 500. American College speak about 400. However, we can go for to be cautious. If more than 400, I will consider it out of diabetic etiology and I will go to treat. If not, I will control the patient first, maybe enough to avoid much drugs, and I will change his anti-diabetic drugs. Maybe if we started, for example, insulin, or started new era of anti-diabetic, he can go for something like that. And I think should be nephrologist to be emerged in the management as the patient has chronic kidney disease.
Can I leave because I have commitment?
Okay, I just give them the summary, sir. Thank you. Thank you, dear
Thank
Professor.
you very much for your all.
Yeah,
Excuse me.
I have,
dear Professor.
Thank you,
okay,
sir.
bye.
Thank you, Professor. I have also from dear Professor Magid that he say about hypoglycemia for this last slide. Yes, I'm with you. I'm just astonished that I found they said that the patient diabetic on treatment, when he receive high intensity statin, usually we know that it can increase hemoglobin A1C. But first time they said when you have serum albumin less than 3.5, they found that this patient could say. I think this is not go more except for observation, okay, and not to reach up to the decision or guidelines or significant amplification. So our key message or our summary today, that atherosclerosis is the leading cause of cardiovascular morbidity and mortality, around 40% in Egypt. Dyslipidemia is the most prevalent modified risk factor, and the assessment of risk is very important, especially in primary prevention, and it should be wide range education and clarification, and pay attention for not only cardiologists but also for internists and family physicians. LDL cholesterol is the target of treatment. Dyslipidemia and high risk and very high risk should be treated aggressively with high intensity statin, and to consider the very high risk patients the same as secondary prevention as having atherosclerotic cardiovascular disease. Diabetes mellitus has different risk categories that we can easily classify, or the risk according target organ damage present or not. If present, very high risk, which is retinopathy, neuropathy, nephropathy. Nephropathy here either high serum creatinine and the low estimated GFR, or positive albumin creatinine ratio and microalbuminuria. Number two, or other risk factors. If there is no target organ damage, we look for risk factors. If we have three at least other risk factors, it is very high risk. If not, and the long duration, it will be high risk. If no risk factors, if no target organ damage and duration less than 10 years, it will be moderate risk factor, but never to be low risk. Non-HDL and apoprotein B are target for treatment instead of LDL in mixed dyslipidemia, as in diabetes mellitus, chronic kidney disease, metabolic syndrome. Lifestyle modification is the cornerstone in the management of primary prevention. Whatever we give medication, you should remember the patient should go for lifestyle modification. And finally, diabetes and the chronic kidney disease with very high risk, the target LDL is 55, non-HDL is 85. And if high risk, the target LDL is 70 and the non-HDL is 100. High intensity statin is a drug of choice for most of cases of diabetes and chronic kidney disease. Rosuva is the best for combination therapy to avoid complications and drug interaction, especially in patients with multiple medications. Thank you.
Thank you so much, dear Professor. We had today a very interesting journey, started from the HDL, its function, and its effect on the risk of the patients. Then dear Professor Hatem did show us a dazzling presentation about the interaction between the diabetes, the chronic kidney disease, and the dyslipidemia, and the risk of dyslipidemia of these patients. We had a very, very interesting discussions and informations and opinions based on the guidelines, and also based upon the valuable opinions of our dear professors, Dr. Hatem and Professor Dr. Suleiman. So, Dr. Muhammad Zahran, Dr. Karim, do you have anything else to add, or any question from the audience?
I have one small comment regarding the dyslipidemia in chronic kidney disease. As Professor Dr. Hatem mentioned, that chronic kidney disease uh, classify the patient with dyslipidemia as being a high risk patient, and when the GFR is less than 30, he will be a very high risk patient. Statin is and maybe a combination with ezetimibe is recommended for the patient with chronic kidney disease. However, if the patient developed end-stage renal disease and be on hemodialysis, statin will have no benefit regarding the prevention of adverse cardiovascular event. So, what do you think, Dr. Hat?
Again, the last statement, please.
If in the patient with hemodialysis, it is not recommended to initiate statin in this patient, as it will have no benefit regarding the prevention of cardiovascular event. This is based on the multiple trial, such as Aurora trial that studied the rosuvastatin in the patient on the hemodialysis and found no benefit with adding rosuvastatin in the hemodialysis patient. And this applies also for patient with heart failure. The initiation of statin in the patient with heart failure, it's not recommended.
And valvular, yes. However, in the guidelines, they said if the patient is already in the medication before dialysis, he can continue.
Yes,
yes. True. Yes.
Yes, Dr. Muhammad. You have a comment, Dr. Stia?
Yes, I fully agree. If the patient is already on statin therapy, he should continue in therapy.
Yes, sir.
Type. What I want to say, if the patient already on statin therapy and he got end-stage renal disease and he is on dialysis, he still got a benefit? And
yes, this is based on the SHARP trial that studied the simvastatin ezetimibe in the patient with the CKD, and they have a sub-analysis for this patient when they develop the hemodialysis. They still have benefit with statin regarding the prevention of the cardiovascular event.
But you speak about other drugs like ezetimibe. Can we give? Is this what you mean?
I think what Karim means that the indication of initiating statin for patient with the CKD, dyslipidemia, and already on dialysis. Should we initiate the drug if the patient did not receive the statin before or not?
I think for primary prevention, no. No more benefit. But let's to make it difficult. This patient suddenly developed chest pain, and ECG showed, for example, STEMI or he got non-STEMI, acute coronary syndrome. I think at the time we will give.
Oh, this is a compelling indication for statin.
Yeah, but for primary prevention, no benefit. You know that this patient with end-stage renal disease, it looks like the same, and on dialysis, like the same when you think about, I'm sorry to say that it's astonishing when you think about to give, for example, you do coronary stenting for a patient with cancer on chemotherapy in the stage, and you think he will not get long run to do primary prevention. He will not get benefit, but he may get complications. May get complications for drug interaction, may get complications for easy to occur rhabdomyocytes or rhabdomyolysis or something like that. So I think, and by the trials, as Dr. Karim said, there is no benefit. They found no benefit. Whatever the explanation, but he will get no benefit. So even if I will not give a statin, no need to give others.
Agree with you, Dr. Hatem. If the patient is already, the patient CKD already on the statin, and he became on hemodialysis, so he should continue statin. Otherwise, the initiation of statin, the patient with end-stage renal disease, candidate for hemodialysis, is not recommended.
Yeah, let's to think about another patient, Dr. Karim. If this patient, her triglyceride, يعني chronic kidney disease is usually has mixed dyslipidemia. If you found there has triglyceride of 500 or 600 and has familial hypertriglyceridemia and not discovered until she got on dialysis, is dialysis will help her for ultrafiltration, or doing ultrafiltration during dialysis is better, or we can give her fibrate or something like that?
I don't have a clear answer. The fenofibrate is not recommended in the patient with a severe reduction of the GFR, and I don't know any recent trial studying the icosapent ethyl in the reduction of
Not yet.
yes,
This is why I'm asking this clinical experience, if you found a case like that, because I received one patient that already on dialysis and her triglyceride is more than 500. At that time, I just recommend her treating nephrologist. I pay his attention that if possible for her to do ultrafiltration for her for triglyceride, no more, yeah. Because I think I have no experience.
I believe in this situation, Dr. Hatton, the best is to treat any secondary causes of hypertriglyceridemia and do a lifestyle modification as far as we can. But the drugs is not recommended with a severe reduction of the GFR.
Yes, yes. Okay.
So at the end of this session, I would like to thank all the speakers and the moderators. By name, I would like to thank, first of all, Professor Suleiman Gharib for honoring us tonight, Professor Muhammad Fatiha, the head of cardiology department at Tanta University. Thank you so much for honoring us by your attendance tonight, sir. Professor Hatem Sukeri, as usual, everyone was dazzled by this very nice presentation, which took the case step by step with all the possibilities and everything. Professor Mona also honored us by her attendance tonight. And finally, last but not least, Professor Raisen Suleiman for this elegant moderation and his interesting lecture about the low HDL. Next week, we will have DVT, pulmonary embolism, and chronic thromboembolic pulmonary hypertension as a cascade of thromboembolic guidelines. It will be very interesting. It will be arranged by Professor Karim Mahmoud. So it will be next Thursday at 9 p.m. also. It will be streamed live on our channel on YouTube, so don't miss it. And see you next week, inshallah.